Online no. So very good afternoon all. Sorry for the delay. There was some technical error. So today in this presentation, we shall discuss about CKRT in children as well as in the neonates. I am Dr. Avinash Reddy, Consultant Pediatric Intensivist, KIMS College, Kondapur. So in this presentation, we shall discuss about the indications of CRRT, types of RRT, mechanism of solute removal, vascular access, knowing briefly about the mission, CRRT prescription, anticoagulation of CRRT circuit, monitoring chart on CRRT, termination of CRRT, and troubleshooting. We'll go briefly regarding all these topics because as such, each topic is around 1 hour topic. We'll go very briefly. Indications of CRRT. So what is CRRT? So this was the definition which was given in the years. It is like an extracorporeal blood purification therapy intended to substitute for impaired renal function. So nowadays, not only for the impaired renal function, because of the other benefits of the CRRT, that is the removal of the fluid, it partially supports the lungs as well as the heart. Removal of the toxin during the acute liver cell failure, it helps in supporting the liver also. And in case of any child with the septic shock and all, it helps in removal of cytokines, inflammatory mediators and all. So it gives partial support to the even other organs also along with the kidney. So it is continuous because it is done over the period of 24 hours. That is the reason we call it like a continuous renal replacement therapy. The terminology has now changed to continuous kidney replacement therapy. So coming to the indication, the renal indications includes any acute kidney injury with uremic encephalopathy along with any pericarditis, acute kidney injury associated with any volume overload such as pulmonary edema if the fluid overload percent is more than 10%. So there was one study which was published in 2018 which says that for every 1% increase in fluid overload percentage, the odds of mortality increases by around 6%. So one should consider CRRT early in such kind of cases if the fluid overload percentage is gradually increasing and which is not responding to the diuretics. And any life-threatening electrolyte imbalance such as hyperkalemia, which are associated with any arrhythmias and all, and other electrolyte balances, so we can consider imbalances also, we can consider doing this CRRT. Or any condition with a severe metabolic acidosis, we can consider CRRT. So the non-renal indications includes removal of drugs and toxins, removal of contrast agents, and acute liver cell failure with hyperammonemia and hepatic encephalopathy, sepsis with MODS, and for removal of cytokines and immune modulation, and inborn errors of metabolism associated with hyperammonemia, for cardiac support for the removal of fluids, tumor lysis syndrome to correct the electrolyte imbalance, and in case of for temperature control in case of hypothermia, which secondary to any drowning or any accidental drowning, all these conditions, these are the non-renal indications for the CRRT. So coming to in neonates, I won't compare between the benefits between CPD as well as CRRT, which is already done in the previous classes. So I'll just briefly go through the indications which we will consider CRRT in the neonates. Any neonate with acute liver cell failure with hyperammonemia, hepatic encephalopathy, or those neonates with the sepsis, with the MODS, with the cytokine storm, and with a very high inflammatory markers which are present in the child. So those form an indication for CRRT. Other children includes inborn errors of metabolism with hyperammonia, which is not responding with medical therapy. We have to consider CRRT. Or those children with post-abdominal surgery followed by sepsis where PD is not possible, we can consider doing CRRT in these children. So when to consider? So whether to consider early or late, or whether it is to consider delayed or proactive. So what does the evidence says regarding this CRRT? So this was the article which was published in 2009. It is an adult article where they analyzed around 1847 patients who were admitted in the ICU, in the 22 ICUs in the Europe. So what they noticed is like the patient who received RRT before they met an AKI3 criteria have better survival compared to those who already had AKI3 stage 3. So definitely there is a mortality benefit if you consider early CRRT. That was an gist of the study. And what does the pediatric evidence says? So this was the article which was published in PCCM in 2014. It says that earlier initiation of continuous renal replacement therapy was associated with lower mortality in critically ill children. So this was a study which was published in a multi-center and over a period of around 10 years, and the sample size was around 350. So what they noticed is that there is a decrease in mortality, which was if the CRRT was considered in early stage. So this was a recent article which was published in JAMA. So it says that those children who are on early CRRT, so there was a mortality benefit, and even the adverse effect following the recovery are also less in those group who were considered with an early CRRT. So here they considered around 1,000 children. It was a multi-center and multinational study which was published recently. So there is a clear-cut mortality benefit if you consider the CRRT in the early stage. So what is early? So the KDIGO had defined that the early is like whenever the kidney capacity exceeds that metabolic and fluid demand which are not met by the kidney. Okay. So those conditions you have to consider using the CRRT at the early stage. So coming to the principles of RRT, so this renal replacement therapy works on these principles, that is a diffusion, ultrafiltration, convection, as well as an absorption. So diffusion is nothing but a movement of solute from higher concentration to the lower concentration across the semi-permeable membrane. So along with the diffusion, so here we can see that this is the fluid with a higher concentration of the solutes, and this is the concentration, this is the side of the fluid where there are less concentration of the solute. We can see that movement of the solute from one side to other side through the semi-permeable membrane. This is the same thing in the filter. So here the blood is flowing from one side and the dialysate is flowing from the other side. We can see that movement of solutes from one side to other side through the semi-permeable membrane. So one should be aware of fixed law of diffusion before going further. The fixed law of diffusion says that the rate of diffusion is directly dependent upon the concentration difference. So how does it help? So we might be seeing in a lot of time in the clinical scenario, many children with CKD presenting to the ICU, presenting to the emergency with a uremic encephalopathy and all. So if we consider doing dialysis, there will be rapid fall of urea, which will be helpful, which will cause the dialysis disequilibrium of the. So in order to decrease that amount of clearance, in order for slow clearance of this urea and all, one can consider co-current flows as co-current flows instead of this counter current flow. So how does this co-current flow helps? Here we can see that concentration differences, and the dialysate as well as blood, I mean the blood as well as the dialysate are flown through the same direction. You can see the concentration difference. After certain distance, the concentration difference will be minimal and there won't be any further exchange. So the clearance will be less in the co-current flow. The same thing if you see in the concurrent flow, here the blood as well as the dialysate are in the opposite direction. So throughout the filter, there will be concentration difference. So that the solute diffusion will be occurring throughout the filter. So the clearance will be more. So one has to choose like which patient we have to consider co-current flow and which patients we have to consider counter current flow depending upon the patient, depending upon the hemodynamic status of the child. And the next principle is ultrafiltration. Ultrafiltration is nothing but movement of fluid through a semi-permeable membrane. So the movement of fluid occurs from high pressure to the low pressure. Here we can consider the movement of water from high pressure to the lower pressure through the semi-permeable membrane. So this is what we call it like an ultrafiltration. And the next principle is convection. The convection is the movement of solute along with the water flow. So here we can see that blood moving from this side, and so the blood after passing through the certain extent, okay, so the along with the blood there will be this convection, ultrafiltration will be keep on going. So there will be solvent drag. So whenever the fluid passes from high pressure to the low pressure, there will be lot of fluid will be transduced from one side to the other side. So along with the fluid, there will be a solvent solute drag will be occurring along with the fluid. So this is what we call it like an convection. So the removal of relatively large volume of the fluid by ultrafiltration, which causes the removal of solute through the convection. This is the basic principle behind that convection. So next final principle is absorption. So the surface absorption, if there are like large molecules which are not able to permeate or migrate through the membrane, there will be other to these pores which help in absorption of the middle to large molecules in the filter. So basically the CRRT works on these four principles, that is diffusion, convection, absorption, as well as an ultrafiltration. Coming to the types and modes of CRRT. So once we open the CRRT machine, we'll be seeing these modes, that is SCUF, CVVH, CVVHD, and CVVHD. What are these indicate? SCUF is nothing but slow continuous ultrafiltration. CVVH is continuous veno-venous hemofiltration. CVVHD is continuous veno-venous hemodialysis, and CVVHDF is continuous veno-venous hemodiafiltration. So what happens in SCUF? So in SCUF, the basic principle is nothing but an ultrafiltration. Whenever the blood passes through the filter, so only the fluid will be filtered from high pressure to the low pressure along the semi-permeable membrane. And after this, the blood will be returned back into the patient. So there won't be any dialysate as well as a replacement fluid. So this mode of CRRT will be helpful to remove the excess fluid from the body. And coming to CVVHF, the basic principle behind is a convection, that is a solvent drag. So whenever the solvent, okay, so here we can see in this diagram. So the blood passes through the filter. Okay, so once after passing through the filter, so the fluid will be lost in the effluent. So along with the effluent, some amount of the solutes, especially the small and middle molecules, will be gone through the effluent. So the CVH to work, it will filter large amount of water. So we have whatever the water which is lost from the body, we have to replace it through the replacement solutions. Here we are adding the replacement fluid. We can add the replacement fluid either pre-filter or post-filter. Once the replacement fluid is added, it is returned back into the patient. So the basic principle behind CVVH is convection, and here there is no dialysate flow, only the replacement fluid will be present. And next is CVV-HDF. So the basic principle behind CVV-HD is diffusion as well as an ultrafiltration. That is a movement of solutes from a higher concentration to the lower concentration, along with movement of water from higher pressure to the lower pressure along the semi-permeable membrane. So it is most effective in clearance of the small molecules only. So this is CVV-HDF, where we are doing the dialysis as well as hemofiltration. So there will be combined mechanism, diffusion as well as the convection. Here we can see that blood is flowing through the filter and along with the dialysate flow. So here we can see the dialysate flow, which is entering into the counter current mechanism. And here the principle of diffusion is occurring. That is a movement of solutes from higher concentration to the lower concentration. As it is a counter current flow, this diffusion is happening throughout. And as there is some convection is also going on, the fluid is getting removed. And along with the fluid, the middle and large molecules are also middle, and to some extent the large molecules also will get removed. And after this removal, the replacement fluid get added. The replacement fluid can be added in the pre-filter as well as the post-filter. Once after adding this replacement fluid, the blood will be given to the blood will go into the patient. So this mode is most effective for removal of small and middle molecules, to some extent to the large molecules. So these were the molecular size and removal. So how to choose the mode in CRRT? So it is based on which molecule we are targeting. So suppose we are targeting urea, creatinine, potassium, and other electrolytes and all. So we can consider dialysis, and to some extent like filtration. When consider both the things, like dialysis is more effective in removal of the small molecules. If you are considering removal of this middle molecule and low molecular weight proteins, such as cytokines complement or any drugs, like in case of drug overdose and all, this filtration will be better than that of dialysis. For removal of water, this ultrafiltration cuff will be better. So this is how we choose the mode of renal replacement therapy. In most of the time in clinical practice, we choose the CBV HDF initially to support, and once after the initial stabilization of this urea, creatinine, and once initially these inflammatory markers start coming down, we can switch off this dialysis part and can continue with the hemofiltration part depending upon the clinical status and all. So this is the summary of different modes of renal replacement therapy. So continuous veno-venous hemofiltration, where there will be only replacement fluids are added, and the basic principle is convection, and CVVHD, where there was only dialysate flow, and there is no replacement fluid, and the clearance is by means of diffusion. And CVVHDF, so there will be dialysate fluid, there will be replacement fluid, and there will be ongoing ultrafiltration also. So the basic principle is convection as well as the diffusion. In SCUF, only this ultrafiltration occurs, that is the clearance of only water occurs through the SCUF. So now we chose that mission, and then we chose like what mode has to be given to the patient. And next is the vascular access. In most of the time in the clinical practice, like if the child is less than 6 kg, we will place like 6.5 French catheter, which are available readily. and the child is between 6 to 10 kgs and all, we'll consider putting an 8 French. And the child is between 10 to 20 kgs, we'll consider putting the 10 French. About 20 kgs, we can consider using 11.5 to 12 French. So that is the thing. And depending on the site of the vascular axis, most of the time, if you prefer, if the child is requiring the long-term CRT, if you anticipate the child is going to require long-term dialysis support and all, we prefer putting this dialysis catheter in the right IJV. And subclavian catheters we usually avoid because there is a risk of vascular stenosis will be there. And femoral vein can also be used. The problem with the femoral vein is like whenever the child starts moving under, the flow disturbances will keep occurring. And the problem is like when the child starts improving under, we can't mobilize the child with the femoral vein catheters. So most of the time in the bigger kids and all, we prefer putting this right IJV. In the neonates, where the length of the catheter is high, like around 10 centimeters, 11 centimeter, when we place the IJV, this catheter can surpass into the right atrium into the right ventricle. So we tend to put the femoral in case of neonates. Now we'll see briefly about the mission, how this mission works. So this was the case of one case we started CRRT in our unit. This is a neonate around 3 kg weight. And if you consider seeing this mission, so this mission has three parts. That is a communication unit, this is a flow control unit, and fluid control unit. So in this fluid control unit, we can see this four bags. This is an effluent bag. This is the PVP bag, and this is the dialysate bag, and this is the replacement fluid bag. We'll come to details regarding the mission in the later slides. And I will explain how the blood flow through this CRRT mission through this video. Okay. So here we can see this blood is drawn. Okay, so blood is drawn from the patient. Okay, here we can see these two tubes. Remember these two tubes. I will come to this why these two tubes are there in the following slides. Okay, so the blood is drawn and through this circuit, it is almost like a 150 centimeters. Okay, it is entering into the machine. Okay, so the once the blood is drawn, the blood passes through this sensor, what we call as like access pressure sensor. And after this, this is the blood pump. Okay, so this pump helps in pulling the blood from the patient. And how much pressure is required for pulling the blood from the patient is determined by this access pressure. Okay, and once the blood passes through this blood pump, okay, here we can see this two tubes entering into this single tube. So here this anticoagulation syringe, this is the anticoagulation syringe. This syringe will be connected here, and this is place where the pre-filter replacement fluid will get added. Okay, so once the pre-replacement fluid gets added and the blood flow circulates through this part, and this is nothing but a filter pressure gauge. So it measures that amount of pressure required to pump the blood into the filter. Okay, so this is a pre-filter sampling port. Okay, which will be helpful in case of if we are considering anticoagulation through citrate anticoagulation. Okay, so once the blood passes through the filter, this is where this effluent comes out. This is where this effluent comes out. Okay, so after the effluent is removed, the blood goes through that. Yeah. So the once the blood goes through the filter, the blood goes through this aeration chamber. Okay, this is an interesting part in the CRRT. So the blood after passing through, it will come to aeration chamber. Okay, so de-aeration chamber basically. So whenever there are any air bubbles and all, will get collected here and it will be removed through this part. Okay, so if you are consider using this post dilution replacement fluid, this post dilution replacement fluid will get added here. If you see this part, there won't be any direct contact between the blood as well as the air. If there is any direct contact, there is a risk of clots will be very high. So there will be most of the time the contact is between blood replacement fluid followed by air. So after this replacement fluid get added, the blood goes through this bubble detector. Any kind of air bubbles it gets detected here, and from there the blood goes into this clamp. Any kind of air bubbles here, if it the bubble detector detects, then this clamp will automatically fall, and this prevents this bubble entering into the patient. So after this wire is entering into this heating coil. Okay, so we'll appropriate temperature is set, and through this heating coil, this blood which is returned into the patient, we can see here. Okay, This temperature maintenance is very important, especially in the neonates. Whenever we are considering the CRRT, so there will be 2 degrees centigrade drop in temperature. So adequate temperature has to be maintained and warmer will be along with the CRRT. So we have to use a warmer which is associated with the CRRT. So this is an effluent line. Okay. Yeah. So this is the effluent. So whichever the effluent is nothing but an waste which is okay removed from the filter. Okay. So which pass through this effluent gauze, and through this effluent gauze, this goes to the static electricity will be nullified here, and from here it goes to the blood leak detector. Any kind of blood in this effluent which will be detected here, if at all blood is present in the effluent, and automatically the machine will stop and it will produce an alarm. So after this, it will go to through the pump. This is the effluent pump, and from this effluent pump, this outflow will be directed to the effluent bag. Here we can see these 4 bags. This is an effluent bag. This is a PVP pre-blood pump bag. This is a dialysate bag, and this is a replacement fluid bag. And this is the communication unit. I'll come to details regarding this communication fluid, unit in the later slides. And this is where we can see how much anticoagulation is seen. And here we can see this info regarding transmembrane pressure and other pressures which are in the CRRT, which we will be seeing in the following slides. So I told there is one interesting 2 wires will be connected here. So this is nothing but the PVP. Okay. So as I told in the earlier slide, 4 bags will be connected. This is an effluent bag and this is the PVP bag. From the PVP bag, the replacement fluid, travels through this PVP pump, and from this pump, this replacement fluid, this PVP replacement fluid will get added into the initial part of the circuit. The benefit of adding a PVP replacement fluid is nothing but it helps in elution of urea, and it helps for better clearance of this urea as well as the creatinine from the RBCs. Okay, so this is the basis behind adding a PVP pump. So here we can see the 4 scales. This is the thing. So this is the blood line, as I told. So the blood is drawn from here. It passes through this, and access pressure gauze, and this is the blood pump. Here in this CRT machine, we can see these 5 pumps. This is a blood pump, and this is that PVP pump. This is the replacement fluid pump. This is the dialysate pump, and this is the effluent fluid pump. Here, as discussed earlier, there is 2 tubes are entering into the main single tube. One side is this is for entering of anticoagulation. This is for replacement fluid, which are getting added up. Okay, and this is the replacement fluid, and this is the replacement fluid pump, which is present. The replacement fluid pump. Here we can see the replacement fluid can be added into the pre-filter as well as the post-filter. Post-filter is added into the deaeration chamber. Okay, and this is an effluent flow, as I discussed in earlier in the video. It passes through the effluent pressure curve and followed by discharging it. It will nullify this static electric discharges, and from there it goes to the blood detector and into the effluent pump and into the effluent bag. So this is the filter. So this is the deaerator or the bubble chamber, and from this it goes into the bubble detector. The blood which is getting returned into the patient, and if any bubble is detected, this automatically the clamp will occur and it will prevent entry of this air bubbles into the patient. So once after knowing the mission, we have to choose what kind of filter and what kind of circuit has to be chosen for this patient. So most of the time in pediatric age group, we use these 3 filters: HF20, M60, as well as an M100. HF20 is designed for less than 8 kgs, and the surface area is around 0.2 meter square. And the blood flow which can be achieved is the least is around 20, and the maximum is around 100. And one should be aware of the filter volume. The total filter as well as the circuit volume will be 60%. If at all this filter volume is greater than 10% of total blood volume, one has to consider priming it with either albumin as well as the normal saline, depending upon the hemodynamic status of this child. So those children who are like more than 10 kgs, we consider using this M60. The blood volume is around 93. And for those children who are around more than 30 kgs, we consider using this M100. So the interesting thing about this M60 as well as an M100 is like there are AN69 acryl nitrate filters. So these filters should not be primed with blood. If you prime with blood, there will be like because of an there will be like inflammatory reaction because of bradykinin release syndrome, and there will be a lot of inflammation will be occurring in the filter, and there will be hypotension will occur following priming with the blood. So consider not to prime the circuit with the blood. Okay, so HF20 circuit can be primed with the blood. So once after choosing this filter as well as the circuit, one has to choose that what kind of replacement fluid or what kind of dialysate fluid or what kind of PPP has to be chosen for this child. So first we'll come for PPP. If you are using an heparin anticoagulation, so we can consider using this normal dialysate or replacement fluid bags for to put in the PPP scale. And but if you are considering the using this citrate anticoagulation, one has to consider using this regiosit bags, okay, in the PPP scale. And we'll discuss about the citrate anticoagulation in the next slides. If you are using this regiosit, okay, in the PPP pump, one has to consider using this bifosil as an dialysate as well as a replacement fluid, because through citrate, actually the mechanism of action of citrate is like it binds with the calcium and it causes regional citrate anticoagulation because of the deficiency of the calcium. So there won't be any coagulation or clots happening in the circuits. So before the blood entering into the patient, the calcium will get added into the patient, and so that the normal coagulation mechanism will be restored in the patient. So it be only this extracorporeal anticoagulation will be given by regional and regional citrate by through these regional citrate bags. Okay, so whenever we are consider using this regiosid, try to we have to consider using this bifosil. So bifosil is free of this calcium. The added advantage of bifosil is like it has an phosphate around 1 to 2 millimoles. Okay, so and the other dialysate fluid which are available is like prismasol as well as a multibic. Prismasol is like a lactate rich okay dialysate and replacement fluid, and multibic doesn't consist of a lactate. It is mostly bicarbonate based, and the good thing with the multibic is like it has a glucose. So those children who has like a higher lactates or who is having this hypoglycemia, one can consider using this multibic from the Fresenius for even the Prismaflex emission also. So we can consider using this okay replacement fluids. So here we can see these 4 units. The bags are same, like these are all these bags are like 5 liter bags, EVP bag, dialysate as well as the replacement fluid bags. So So what is the advantage of pre versus post filter replacement fluid? So if we consider adding this replacement fluid in the pre-filter, it dilutes the blood before the filter. So because for dilution, there won't be like a thick blood that is passing into the filter. So because of the dilution, there will be like a blood will be thin, and this increases this life of the filter, and it reduces the clotting in the filter. So, but the problem is like because of the dilution, there will be decrease in the clearance. So one has to consider increasing the blood flow, okay, to in order to compensate this decrease in the clearance. So if you consider adding in the post filter, okay, so there will be increase in need of anticoagulation to prevent any clotting in the filter, and this dilution occur. There will be a good amount of clearance if you consider adding post filter replacement fluid. So these are the advantages and disadvantages of pre-filter and post-filter replacement fluids. So next coming to the CRRT dosing. Okay, CRRT dosing is nothing corresponds to the effluent flow rate. So KDK practical guidelines recommend a delivered dose of around 20 to 25 ml per kg per hour. Okay, so delivered. So there will be always a discrepancy between the prescribed as well as the delivered dose. So one has to prescribe the dose of around 30 to 35 ml per kg, so that the delivered dose will be around this 20 to 25 ml per kg. Why this discrepancy occurs is because of pre-dilution, with the replacement fluid. So there will be dilutional factor also will be going on. So the effective dose will be considered less, okay, when considered to prescribed dosage. So one has to consider using this, okay, prescribed dose as around 30 to 35 ml per kg per hour. It is a standard dosing of CRRT. So once if the child is having any hyperammonemia or the child is in shock with high inflammatory markers and all, one can consider using this high volume hemofiltration or high volume CRRT in this condition. So the dosing goes up to 80 ml per kg per hour. So it all depends upon the hemodynamic status and condition of the child, and so why we are doing the CRRT. But most of the time the standard prescription of 30 to 35 ml per kg per hour is used in the clinical practice. So this is how we start the CRRT prescription. Okay. So the CRRT prescription. Okay. So this is the CRRT prescription. If we see the mission, this is that communication unit. Following parameters can be set. Okay. So the blood. So usually we target this blood flow rate between 5 to 8 ml per kg per hour. And so sometimes depending upon the hemodynamic status, we can consider using till 10 ml per kg per hour. This 5 to 10 ml per kg per hour is extrapolated from the adult many studies where they observed is the least hemodynamic compromise and good amount of clearance with this amount of blood flow. Okay. And the next thing we see is a pre-blood pump, and next thing we see is a dialysis fluid. So initially what we have to consider setting is like a blood flow rate and followed by effluent dose. Okay. So how much dosing we have to consider? Here, as the child is having this sepsis, okay, so we consider higher effluent dose. So, in order to remove these inflammatory markers and all, so here we consider the dose of around 70 ml per kg per hour. Okay. So, once after this effluent dosage is determined, we have to divide this effluent dose into half into the replacement fluid and half into the dialysate fluid. So, this 212 ml per hour, we divided half into the dialysate fluid, that is 100 ml per hour, and the remaining half as a replacement fluid, 80 ml per hour, and 30, 80 plus 30 around corresponding to around 110, and the total is nothing but an effluent dose. Here we kept the patient fluid removal initially as a 0 to achieve this hemodynamic to prevent any hemodynamic imbalance initially after starting this CRRT. So this is how we make a prescription. Here the child is around 3 kg, so we started with a 10 ml per kg. So of a blood flow, that is 30 ml per minute, and effluent dose we kept around 71 ml per kg per hour. Okay, half the effluent dose as an dialysate and remaining half as a replacement fluid as well as an PVP. And initially we kept the patient fluid removal as 0 ml per hour. Okay, this is how we set that CRRT prescription. And we can see here it's like a filtration fraction around 8%. So what is this filtration fraction? So it corresponds to the fraction of fluid removed from the plasma at the level of filter through the filtration. So the filtration fraction is nothing but ultrafiltrate rate divided by plasma flow rate. So ultrafiltrate rate includes pre and post replacement fluid as well as PPP and patient fluid removal. Okay. So the rule of thumb is always try to keep this filtration fraction less than 25%. If the filtration fraction increases, the risk of clots in the filter will be increased. So ultimately, we have to prolong the filter life. So consider keeping this filtration fraction less than 25%. So coming to the anticoagulation, as the blood is drawn out from the body, the risk of the risk of clots will be very high. So to prevent the clots, one has to consider adding an anticoagulation into the CRRT extracorporeal circuit. So the most commonly used thing is unfractionated heparin. Okay. So in our unit, what we practice, we tend to start unfractionated heparin between 5 to 10 units per kg per hour, and we target these APTT levels between 45 to 60 or 1.5 to 2 times that of the normal range. So the main advantage with unfractionated heparin is like it is easily reversible with protamine, and the half-life is around 90 minutes. In case of any kind of procedure also, you can consider stopping it like 2 hours before the procedure. And the problem is like the main disadvantages is like a patient bleeding, and most of the time if you are using for sick children and all where these coagulation parameters are deranged, the risk of bleeding will be high with heparin. And other disadvantages heparin induced thrombocytopenia. So other commonly used anticoagulation is regional citrate anticoagulation. Here, if you are using this regiosid bags and all, the starting dose will be around 3 millimoles per liter. Okay. So one has to monitor this intracorporeal as well as extracorporeal ionic calcium. So once this citrate enters into the blood circuit and it binds with the calcium, and the calcium won't be available for the clot, so the clot won't be formed. Okay. So we may try to maintain this extracorporeal ionic calcium around 0.25 to 0.35 millimoles per liter. So once after this blood passes through the hemodialysis filter, so this calcium gets added into that return line, and the blood is returned into the patient. So this is how regional citrate anticoagulation is performed. The main advantage is like the anticoagulation is like an extracorporeal. It's like a regional to the circuit. There is nothing extra amount of citrate going into the patient, and there will be lower risk of bleeding, and then the filter life will be longer when compared to that of heparin. So the main disadvantage is like we need a strict protocols regarding the management, regarding this monitoring of citrate levels and monitoring of this ionic calcium in the extracorporeal as well as in intracorporeal, intracorporeal ionic calcium levels. So there will be, because of a large amount of PBP will be added into that blood. So they have to increase this dialysate dose to for increasing the clearance. If you are considering using this regional citrate anticoagulation. So other commonly used, other commonly used, especially in those children which are who is having liver cell failure, is like prostacyclin anticoagulation. It is prostacyclin infusion. It is considered between 2 to 8 nanogram per kg per minute. So there won't be no need of any anticoagulation parameters to monitor. Okay. So the main problem with prostacyclin infusion is like there can be systemic hypertension as well, because secondary to the vasodilation, and there will be there can be possible raised ICP is possible. So the commonly used thing is unfractionated heparin as well as regional citrate anticoagulation, and depending upon the unit and depending upon the child, like in those children with acute liver cell failure, and prostacyclin infusion can be considered. It is not that easily available in India. Coming to the liberation from CRRT. Liberation is the removal from the CRRT. I mean, when to consider stopping this CRRT. So whenever the underlying kidney function starts improving, one can consider liberation from CRRT. So by the clinician, I mean the treating person can give the filter holiday if the urine output is greater than 0.5 ml per kg per hour, and the fluid as well as acid base and electrolyte imbalances are corrected prior to the filter holiday. Coming to the monitoring. So following things has to be monitored whenever we start the children, CRRT. So here, this is the monitoring chart which we usually follow. Okay, here we can see like which mode of CRRT which we are using, and this is the machine which we are considering using. And we have to examine the catheter daily during the rounds, like to see what's happening around the catheter, any extravasation is going on, what's happening with the dressing, okay, any soakage with the dressing, all those things has to be checked. Okay, and what type of dialysate is considered, what type of replacement fluid is considered, and when was the time this replacement fluid has been loaded into that machine. We have to mention these timings and all. We have, okay, and what type of filter is used, and what day of filter it is considered, and what type of anticoagulation, whether heparin anticoagulation or citrate anticoagulation, what was the calcium levels, okay, what was the peripheral as well as an post filter ionized calcium. All these levels has to be monitored, okay, accordingly. And here we have to check about this ultrafiltrate clearance. So we are based on the time we can monitor this effluent volume, dialysate flow, net ultrafiltrate, okay, replacement fluid which is given to the patient, and based on the timing this arterial pressure, filter pressure, effluent pressure as well as venous pressure should be monitored, and any hemodynamic medication which are going to the patient should be mentioned here. And coming to the laboratory, okay, monitoring. So we consider the monitoring of ABG and as well as an electrolytes every 8 hourly, and calcium, magnesium, phosphate we consider monitoring every day, every 24 hourly, and urea creatinine every 24 hourly we'll consider monitoring, and according to the timing. So these values should be mentioned, and these values should be serially followed. Coming to the troubleshooting. So this is the communication unit. Okay, this part of the communication unit we already discussed. Now we'll see about the troubleshooting. So here we can see that the four pressures which are being measured here, and two pressures which are being calculated. That is a pressure drop as well as the two TMP. So these four pressures are like access pressure. So access pressure. Okay. So access pressure. I'll show the where all we'll measure these access pressures and all. So this is where we measure this access pressure. This is where we measure this filter pressure. Okay. And this is where we measure this effluent pressure. Okay. This is where we measure this return pressure. This is the return pressure cause. Okay. So the normal access pressure should be between -50 to 200. If at all it is going too negative, so that indicates that the machine is doing too much of work to extract the blood from the patient. So this happens whenever there is the circuit is clotted or there is a kink in the circuit, the access pressure becomes more negative. Okay. And coming to the filter pressure, it is on the highest. This is a positive side. I mean the amount of pressure which is required to pump the blood into the filter. If at all the filter is getting clotted or the filter is getting clogged, so the filter pressure will start rising. So If the filter pressure starts rising, one has to see this return pressure. If the return pressure is elevated and filter pressure both are elevated, one has to consider there is a kink or clot in the return pressure return line. If the only filter pressure is elevated, one has to consider clogging or clotting is going on in the filter. So this is the access pressure and these are the return pressure. So if the high return pressure is it is above 300 mm of Hg, the vascular consider we have to the vascular catheter is clotted or kinked, and one has to go and check the position of the catheter. If there is a low return pressure, we have to see whether there is any disconnection is present or not. We have to go and check. So this is about the filter pressure which we discussed earlier, and last is the transmembrane pressure. It is a positive pressure difference between the blood as well as the ultrafiltrate. Then normally the TMP should be less than 250. The alarms will be keep on going if the TMP is greater than 450, and that indicates that the filter is clogged or there is a clot or embolus in the filter or excessive ultrafiltrate related to the blood flow rate is going on. So these pressures we can access through here. So this is the access pressure, this is the filter pressure, and this is the effluent pressure. The amount of pressure which is required to draw the effluent volume from the filter is nothing but an effluent. It can be negative as well as a positive depending upon the mode we are using. And this is the return pressure. Return pressure will be most of the time it will be on the positive side. The normal return pressure between plus 52 and plus 200. These two are the calculated volume pressure drop. If the pressure drop is keep on increasing, that indicates that filter is getting clogged or filter is getting clogged. Any acute rise in the pressure drop, that indicates that the filter is getting clotted. So these are the things. So this is how you'll troubleshoot this CRRT mission. So in this presentation till now we discussed about okay. So what are the principles okay behind the CRRT? That is diffusion and convection as well as ultrafiltration, okay, and as well as an absorption. And following that modes of CRRT, how to choose these modes of CRRT between CVVH, CVVHF, CVVHDF as well as the SCUF. After selecting these modes and how to consider this vascular access depending upon the age, and following that, how to set the prescription, how to set this CRRT dosing, how to set this blood volume, and how to select this circuit, okay, depending upon the age, okay, and following that, how to consider this anticoagulation, and last is the troubleshooting. So this is the brief thing about how this CRRT works, okay. Thank you.